Although use of prosthetic mesh repair or prosthetic repairs has been established as the gold standard in the management of uncomplicated groin hernias, however, its use in the setting of acute incarceration and or strangulation has remained very limited. This is because the classic surgical teaching contraindicates the use of prosthetic repairs in the setting of acute incarceration and strangulation, and thus subjecting these patients to an avoidable high risk of recurrence. The main reason remains to be an assumption that the use of prosthetic repairs in the setting of acute incarceration and or strangulation would be associated with a significantly higher rate of mesh-related complications. When you review the literature, you would find that this is an assumption that is neither based on nor supported by any clinical evidence. And the literature, on the contrary, is full of various examples of surgeons using prosthetic repairs in the management of different types of hernias. This is a list of the studies that have used mesh or prosthetic repair in the emergency management of groin hernia. You can see that the mesh infection rate is nearly zero. And this is another group that used the emergency open ventral hernia repair, and the number of mesh infections is very, very, very low, negligible. And this is in the management of, in the laparoscopic management of incarcerated or strangulated hernia. Again, mesh infection is negligible in potentially contaminated fields where an open bowel has been, where there is open bowel and resection anastomosis, and in potentially contaminated fields that like parastomal hernia repair. So the aim of the present work was to present a 10 years experience in the use of prosthetic repair in the management of the acutely incarcerated or strangulated groin hernias with a performed عند الهيباتوبيلياري pancreatic surgical unit. The inclusion criteria included these patients admitted to the emergency department with this condition. The presence of non-viable intestine and the necessity to perform intestinal resection was not considered a contraindication for mesh repair. And however, we excluded patients where there was pus in the hernial sac or generalized peritonitis, which is very rare. These are the usual preparations: antibiotics, IV first, then continues orally. For obese, we gave heparin, and the use of general or epidural anesthesia. For ill patients, a polypropylene mesh was used for the repair. And this is the scheme of follow-up. From January 2003 through January 2013, 234 patients were operated upon. Their age ranged from 16 to 85 years with a mean of 55 or 56 years. Most of them, of course, in the groin region were male. 91% were males. The BMI ranged from 25 to 34 with a mean of 29 kilograms. This is a list of the associated comorbidities. On top comes hypertension. And the time lapse from the start of acute incarceration till the start of surgery ranged from 1 to 48 hours. The median was 7 hours. The types of hernias, 87% were primary hernias. And this is the distribution of groin hernias encountered. On top of the list comes indirect inguinal hernia with nearly 86%. 5.5% were hernia of canal of neck. 6.5% or 6.4 were femorals, and 2.1 were direct hernias. The right side predominated. 73% of the incarcerated or strangulated hernias presented as right side hernias. The small intestinal content was in 75%. Colon represented as a content represented only 15%, and omentum represented only 10%. Viable contents were encountered in 82%, and non-viable contents were encountered in 18%. The non-viable bowels that were resected and in this series were 15% of all patients presented with either colonic or small intestinal content in the hernia. The perioperative mortality was 2.1%. We have 5 patients who died within the first post-operative month, either of myocardial infarction, وده كان the night of the operation or the next day, and progressive liver failure on those who presented with cirrhosis. The complications were encountered in 41 patients and 17.5%. They included wound infection, scrotal hematoma, chest infection, deep vein thrombosis, and transient deterioration of liver function. Mesh infection was encountered in only one patient. When we compared the patients with viable contents and the patients who had non-viable contents, we found that the differences between both was not significant. Especially, you have to notice that the difference that the mesh infection occurred in a patient who had viable content where no resection anastomosis was performed. And this is the only patient. The hospital stay ranged from 1 to 13 days with a mean of 2.7 days. The follow-up duration ranged from 6 to 120 months with a mean of 62.5. And this table shows the follow-up, the results of following up at the third post-operative year. We had 95% of the patients available for reassessment. By the 10th, we only had 86.3% of the patients who were operated upon available for assessment due to death, either perioperative or death due to unrelated causes, and those lost to follow-up. We don't know how to reach them. Throughout the study period, 2 patients developed recurrent hernias. Only the recurrence is less than 1%, as with any Liechtenstein, for instance, repairs. And the use of prosthetic repair in the management of the acutely incarcerated and or strangulated groin hernia is safe, it is efficient, and is not associated with an increased incidence of mesh-related complications. And resection of non-viable intestine cannot be considered a contraindication to the use of prosthetic repair. Thank you.